I welcome all the faculties and delegates for the Searchlight 11. This is the Core Connect live webinar, which is on the topic of updates in obstetric Dopplers. This webinar is initiated by Cancer Prevention and Relief Society in association with Bharatpur, Bharuch, Bhavnagar, Bhiwani, Bhuj, Bidar Ops and Gynae Society, as well as with the Society of Fetal Medicine, Chhattisgarh. So it's my privilege to welcome our convener, Dr. Sujay Sri Sangeeta. Dr. Sujay Sri Sangeeta ma'am is a founder secretary of Bhimavaram Ops and Gynae Society, and currently she is practicing as a consultant obstetrician and laparoscopic surgeon at Shishadri Hospital. And madam has presented so many posters in many conferences, as well as madam is this associated with the and conducting one program, that is the Vikasam, which is on the awareness and spreading the knowledge about the menstrual hygiene to the adolescent girls. So I welcome ma'am and requesting you to please proceed this webinar ahead.
Sure. Thank you for that kind introduction, Mr. Mehul. So I would like to introduce Dr. Asha ma'am. Could we have the screen for the same? Yeah, it's my privilege to introduce ma'am to everyone. Ma'am is actually the director of SMSA Hospital, Raipur. She is also the medical director, Cancer Prevention and Relief Society. She is the elected member, CG Medical Council, Vice President, IMA Chhattisgarh, Zonal Chair, Foxy Food, Drug and Medico-Surgical Equipment Committee, West Zone. She is the chairman of the Mission Pink Health, IMA Raipur, and executive member of ISCCP. Her previous posts have been, she's been the past president of Raipur Society, past secretary of IMA Raipur, and also the president of Rotary Club of Raipur. So ma'am's fields of interest are saving the uterus, fetal medicine, obstetric and gynec ultrasound, critical care, preventive oncology, and colposcopy. So this is madam's dream project, and this topic is very close to ma'am's heart. So hoping the session will go without any hitch. I request ma'am to please take over and introduce the chief guest and guest of honor.
Namaskar. I welcome everyone to this program. And before we officially start the program, we would pray to the divine for blessings, and then we will take blessings from our seniors and faculties. So may we have the prayer, please.
Vakratunda Mahakaya Suryakoti Samaprabha Nirvignam Kuru Me Deva Sarvakaryeshu Sarvada.
With that, I welcome all the faculty from Bharatpur, Bharuch, Bhavnagar, Bhiwani, Bhuj, and Bidar Obstetric Gynec Society. And I also thank the Society of Fetal Medicine Chhattisgarh for joining me in this webinar. I thank our chief guest, Dr. Ashok Khurana sir, who actually picked up my call at the first ring and agreed to be the chief guest here. He is my mentor who started me and made me fall in love with fetal medicine. So welcome, sir. It is a real honor to introduce you here. Though you don't need an introduction, but it's an honor to me to introduce you. Sir is an MBBS MD radiodiagnosis from India. He is an MBBS from AIIMS New Delhi, MD in radiodiagnosis also from AIIMS New Delhi, and trained at the Harlev Hospital in Denmark in ultrasound. He is a chairman and consultant in reproductive ultrasound at the Ultrasound Lab, New Delhi, and he's been practicing ultrasound since 1980. He is the professor, School of Health Sciences, Dubrovnik, International University, Croatia, Professor, Indian Medical Association 2017 to 20, past president of Society of Fetal Medicine and the patron forever of the Society of Fetal Medicine India, former ISWAG ambassador in India, former dean, Indian College of Medical Ultrasound, mentor emeritus, Society of Fetal Medicine, and editor-in-chief of the Journal of Fetal Medicine. Welcome, sir. We are honored to have you and would love to hear some words from you on this webinar and the topics chosen.
Thank you. Thank you very much. First of all, thank you for having me here. It is indeed an honor, and it's great to be amongst friends. And it's so nice to see so many young stars shining and ready to take on the world and teach all of us what's new and what is standard. And my congratulations again. It's also very nice to know that this is part of a much larger event, the Searchlight program that you put in place. And of course, today we will be listening to the updates in obstetric Doppler. And I just love the alphabetical way in which you included all the OBGYN societies, so that at the end of Searchlight programs, we will have just about everyone well informed, and they will have access to this information. And of course, your local chapter of the Chhattisgarh Society of Fetal Medicine is here in full strength, and it's wonderful to see them here. I'm so pleased you've chosen these topics carefully, because truly speaking, it's intimidating. But once you know what it is all about, you realize, wow, how did I do without it? And that is what I look forward to listening to today. And we have excellent speakers, and Chinmay, who is such a lovely bright spark and uses this in his life every day. We have Bijoy Balakrishnan with his wisdom of experience, and of course you to moderate a panel of very illustrious panelists. Each one of these topics is going to teach us on how it is important today in ultrasound, not just to assess fetal anatomy, but how it is important for all of us to actually assess fetal physiology, and of course try and understand the pathophysiology, because therein lies the ability to save a fetus and save a mother. We do understand that Doppler now is not just for fetal health, but maternal health as well, and that uterine artery Dopplers themselves lend themselves to something very important, which is what I refer to as the rest of the world is now doing as the fourth trimester of pregnancy, which is the postpartum period and beyond, where it tells us that, look, these mothers might be very dangerously ill in the future, and we need to look after them. I'm sure we'll be covering that as well today. So over and back to you, and thank you once again for having me here.
Thank you, sir. Thanks a lot for that. And it's an update, and our speakers are definitely going to do justice. I deliberately took singleton pregnancy this time, because if you mix in twins, then it becomes difficult to comprehend and the take home becomes very low. So maybe we'll do that later, but this time it's singletons, and thank you so much for those words. Thank you, sir. May I have Shamal sir's CV, please? Welcome, Shamal sir. He is the VP elect Foxy. He's a consultant practicing gynecologist at Kolkata, also a medico-legal advisor. He's a visiting specialist at Woodlands Multi-Speciality Hospital, Bellevue Clinic, and Zenith Super Specialist Hospital. He's the honorary secretary of the Bengal Obstetric Gynec Society 2015-16, chairperson MTP Committee 2015-17, organizing secretary Endogen 2017, Endogen 2018, and Endogen 2019. My God. Vice President, the Bengal Obstetric Gynec Society 2016-20, and also in 2023. And he is the Vice President-elect of Foxy 2025. He also took my call at one go and agreed to be here as our guest of honor. Welcome, sir, and over to you for your words. Shamal, sir? He's there, but he isn't speaking.
Yeah.
Mehul, may I have Bela ma'am's CV?
Yes.
In the meantime, I just got
Yes, sir.
So long I was not allowed to be unmuted. Anyway, thank you very much, madam. It's for your kind invite. And the importance of Doppler in pregnancy, what can express about the utility of the Doppler services. And these days, when we are going through any kinds of pregnancy as a valuable pregnancy. Now, in our student days, there are certain categories of pregnancy. We used to stamp those as high-risk pregnancy or specially valuable pregnancies. Now we are in an era where each and every pregnancy is a valuable pregnancy, and a role of Doppler study in pregnancy, starting from the first trimester anomaly scan, and up to how the growth scan and monitoring the Doppler study at 36, 37 weeks regarding your decision to take out the baby or decision in high risk cases when you are going to plan for the delivery or induction of labor, whichever way you are. It's of innumerable value, and I believe this webinar will be of immense help to all of us practicing gynecologists, not to say only of those who are practicing the imaging science or the sonologists, but for us, the gynecologists, I believe it's of huge help for all of us during practice. Thank you very much for all these efforts to bring in this subject as the topic of your context. That's very nice. Thank you very much again for your invite. And I believe the program is going to be of help, whoever is attending. Thank you very much, madam.
Sir.
Thank you so much.
Thank you, sir. Thank you. May I have Bela ma'am's CV? So Dr. Bela Bhatt ma'am is a dear friend. She is currently the chairperson of the Foxy Imaging Science Committee. She is the lead consultant, Dr. Bela Women's Hospital and Fetal Medicine Center, Andheri, Mumbai. Fetal medicine consultant at Dr. Balasaheb Ambedkar Memorial Central Railway Hospital in Mumbai. She is an FMF UK certified sonologist for fetal abnormalities, also for nuchal scan. She is a life member of Society of Fetal Medicine, Joint Secretary, AFG Mumbai, Managing Council member, ISPAT. She's got the CS DON first prize at AICOG 2018 Bhubaneswar. Winner first prize of Foxy Has Talent National Competition 2018. National convener for Foxy Superstar Competition 2019 to 20, and National Talent Coordinator Foxy Has Talent 2022-23. We've all seen how beautifully she dances, and I think she makes the fetus also dance to her will. So over to you, Bela ma'am.
Thank you so much for those beautiful word of introduction, Dr. Asha Jain. Yes, Dr. Asha Jain has been a great friend, and thank you so much for making me part of this wonderful webinar, where we have dignitaries like Dr. Ashok Khurana there, Dr. Shamal Sheth, and the speakers, what to say about them, Dr. Chinmay Umarji, Dr. Bijoy. I mean, everybody knows them and how knowledgeable and good they are at their work and in the field of fetal medicine. The topic that has been chosen today is really, as already mentioned by Ashok sir and Dr. Shamal Sheth, that not just doing Dopplers, but interpreting them is extremely important. And that's what you have concentrated on in this webinar, which is really good for each and every obstetrician to help manage their patient, because we know right from early pregnancy till delivery, we need ultrasound for each and every case, Dopplers especially. Now, when I looked at the list of societies that you have included, you may not be knowing, but I have been part of Bhavnagar OG Society for 10 years. So good to see that Bhavnagar is also there in this. Bharuch, Bhuj, all societies from Gujarat, and of course Bharatpur, Bhiwandi, and Bidar societies. So good to connect with all these societies through this. And I'm sure after this two wonderful talks on Doppler, Dr. Asha Jain, you are going to do a great job by moderating a panel on the same with the kind of faculties that you have. So thank you so much for having me here today. And if you remember, I have been there at Raipur physically for one of the CMEs. And so it is again very nice to connect to all of you online. Thank you so much.
Thank you, Dr. Bela. You recognize my Center for Ultrasound Training in Foxy.
Yes. And all
How can I forget?
Yes. And all the very best for your future endeavor in Foxy as well.
Thank you. Thank you so much. So before I actually hand over to the conveners, I just want to share with my guests here that the reason I chose this topic was that not every gynecologist will be doing the Doppler, but at least they should be able to interpret and see in the image that it is correctly done. Otherwise, what happens is they get a report that, there is a notch or there is some, the PI is high, and they get so tense and it goes into preterm delivery most of the time. So what is happening is that because the Doppler, anyone who's doing Doppler will be able to say, Chinmay sir will be explaining now, that a little bit of change of angle and you can get any report you like. So the gynecologists who are attending this, my request to all of you, please listen carefully, even if you are not doing. When you see the image, you should be able to see whether it is correctly done and whether you should really end up in a preterm or you can wait. So I hope it helps you in your daily practice and decision making in obstetrics. And that is the objective of this webinar. Thank you very much. Over to you, Sujaya, to take the session forward.
Ma'am, unmute. Ma'am, Sujaya ma'am, please unmute yourself.
Sorry, I'm really sorry. I didn't realize. Yeah. So we'll begin the first session for today. The topic is indications and technique of obstetric Doppler in pregnancy. I will first be introducing the chairpersons for today's session. Mr. Mehul, please share the slides, please. Yeah. So we have Dr. Swati Kumari with us. Madam has done her fellowship of National Board in high-risk pregnancy and fetal medicine from Fernandez Hospital, Hyderabad. She's a consultant fetal medicine. So thank you, ma'am, and welcome to today's session. We have Dr. Ritu Gupta with us. Madam is the director of Dr. Vinod Gupta Hospital in Bharatpur. She has been celebrating humanity for the last 23 years, and she's the president of the OB-GYN Society from Bharatpur. Welcome, ma'am. We have Dr. Hiral Pandya, ma'am, who's the secretary of Bharuch Obstetric and Gynaec Society. She's working at Sevashram Hospital for the last 19 years, and her hobbies are painting and gardening. We welcome you, ma'am, for today's session. I request one of you to please introduce the speaker for today. Ma'am, anyone can please come forward and introduce the speaker. Hello. Okay, I will introduce Dr. Chinmay, sir. A very warm welcome, sir. It's very nice to have you with us here today. Sir has completed his MRCOG from London. He's done his fellowship in fetal medicine. He's a consultant at Umarchi Hospitals, in charge of the fetal medicine unit in BJ Medical College and Sassoon General Hospital. I hope I got it right. He's the secretary for the SFM Greater Pune chapter, and he's the president-elect for the SFM Greater Pune chapter. So we welcome you to, sir. You can please start the talk.
Thank you, Sujayashri ma'am. At the outset, I would like to thank Asha ma'am and congratulate her for choosing such a wonderful topic. As she rightly said, we need Dopplers every day, and it's going to change the way we manage our babies. And also for the opportunity to be here on this platform, I would like to thank SFM Chhattisgarh, Khurana sir. My mentor is here, and it's such a great privilege. With your permission, I'm going to share my slides and just, yeah. So it's about indications and technique of Dopplers in pregnancy. And anybody who is now doing JR1 in a medical ward would say that indication of Doppler is fetus in a gravid uterus. You want to know everything about the baby. You want to know everything about the uterus. And what better than a Doppler to tell us about the trajectory? And the beauty of Dopplers is that it can tell you the trajectory not only for the baby, until delivery, but also for the mother and her cardiac health, even till later life. On a more serious note, of course, I'm trying to keep it very, very basic. We want to use Dopplers only to confirm fetal demise. Please mind you, Dopplers should not be offered in the first trimester. The safety is yet to be established. However, if you are quite certain that the fetus has had a demise and you want to just confirm it and kind of counsel the patients with the help of it, the blue and red colors help you a lot. So putting a small color box on that tiny heart and showing that there is no heart can sometimes be quite confirmatory for the patients, and it increases your ease of counseling. Apart from that, of course, we use Dopplers in the first trimester and of course later on to understand the uterine arteries, umbilicals, cerebral, and ductus venosus circulation. I'm sure Bijoy sir will explain all of this to you in the subsequent talk. So today, for the ease of basics, I'm going to stick myself to the technique of Doppler. As Madam said, the physics of Doppler is very, very interesting, and we do need to understand it very well. I'm not going to touch on that aspect today. I'm not going to tell you about the probes you want to use, the various features the new machines are offering, which have made the access so much easier. But I'm just going to stick to the basics and tell you about how to use color or power Doppler, how to use pulse, what is the importance of angle and gate, especially for certain particular Dopplers, and then how to plot. Interpretation of plotting, I leave it to my subsequent speaker. Uterine artery, of course, you know how it comes. You know that it branches out from hypogastric, and it comes at the level of the cervix. It is like bridge over the water called ureters, and then it gives a descending branch and starts ascending up. That is where you want to sample it. Uterine artery is important to let us understand the circulation which is currently going to the baby and the effects it may have later on in our life, as all of us know, preeclampsia and fetal growth restriction mainly. The important part is how to locate a uterine. For the sake of today's discussion, I've kept only abdominal sampling of uterine, but yes, you can also do vaginal sampling, which we usually encourage at the time of first trimester NT scan. And in vaginal sampling, it's very, very easy. You go inside with the probe, you just go 30 degrees laterally, put your color on, and boom, you see your uterine there. And the same technique, which is slightly more difficult with abdominal method, I'm going to teach you that right now. So I hope my audio is seen. Here I am. I'm trying to locate the lower pole of the uterus. I see a cephalic baby there. I'm going to the left iliac fossa. I see there are certain vessels there. Even without the Doppler, I'm able to see the vessels. Now I put my Doppler on. And I see there is a crossover. What is this? This is your uterine coming inside, branching out of the hypogastric. And then I sample it with the help of a 2 millimeter gate onto the Doppler, where I'm trying to insonate it at the right angles to get a good peak systolic velocity above 60 centimeter per second. Please remember, 60 is very, very important. Are my videos seen?
Yes, sir, they're visible, sir. They're
Thank
very
you.
clear.
Thanks so much. So 60 is a very important landmark here. Moving on. So now let us see in continuity in real life, how does one do that? Please tell me if my audio is audible.
So you're audible. The video has yet to play.
Yeah, I think it's playing. Just 1 second. Today, we are going to learn how to acquire major and clot terrain artery Dopplers third trimester. For uterine artery Doppler, it will go lateral as you can upon the and put into the uterus. Remember, you are not going to find it inside, but on the bed. As you go parallel, your internal IDM artery, find an option given time the internal IDM, which crosses over internal IDM for almost 90 degrees. Adjust your pulse repetition frequency as shown on the screen. So that the color does not split out of pressure. Okay. As you can have the pregnancy, as with high flow, we find adverse.
So the audio is not very clear. Could you provide
Yeah,
some voice
sure.
to it?
I'll give a live commentary.
Yeah, that would be better.
As you can see, I've adjusted the color there, and I can see the crosser of internal with uterine, and I've just sampled it with a gauge size of 2 millimeter with pulse wave Doppler, and now I'm going to measure it. I'm confirming that the vessel I sampled is correct. It has peak systolic velocity of above 60. So I'm quite sure that I've sampled my uterine, and I'll hand it over these readings of uterine artery PI and RI to Dr. Bijoy for further interpretation in the next talk. Now let us move on to the next slide. So this is just an image of the same artery sampled vaginally. So this is how we sample it transvaginally. I'm not going to go into those details today for this audience. Now, as we know, when we are looking at fetal growth, umbilical arteries are absolutely important. We know that they reflect fetal health, and the Dopplers, if they are showing more resistance, we are anticipating poorer outcomes for the babies. So let us see how simple it is to sample these arteries. Again, we are going stepwise. The first step is to locate. Second step is to put color on. Third step is to put pulse wave Doppler on. And most important step is to plot your vessel on the nomogram. Now with umbilical, what you need to remember is that the sampling you want to take should be in a free loop of the cord. So you should have nice free loop of the cord floating in the amniotic fluid. Then you choose a loop which is giving a flow towards your transducer so that you're sampling it at right angles, and then you put the pulse wave Doppler on. Sometimes this may not be that easy, especially in cases of oligoamnios when you're dealing with twins. And that is the reason why I think Dr. Asha has kept those lectures apart from today's lecture. So let us just go with the basics and then we can go further ahead. So in umbilical artery Doppler, again, localizing it is very, very easy. You can see those beautiful loops of cord over there. You're going to choose a nice free loop and you're going to sample it with the help of the color. Then you put pulse wave Doppler on, and then you look at the umbilical PI and RI, plot it on the nomogram and see how it goes. Let us see again how this is done live. So I'm looking at my fetus. On the right side of the mother, I see some water. On the left side again, I see some water. That's a beautiful place to sample umbilical artery there. As you know, the cord is always going to be around the head and near the neck, again, which is very easy and not an indication for cesarean. So we look at the umbilical artery and we put color on over here. You see there, color is spilling out of the vessel. This is because the velocity on the Doppler is not, on the probe is not matching with the velocity of the vessel. So you adjust the PRF and then you see the color is now sticking to the walls of the vessel and you can sample it beautifully well over there. You measure it at least on the 2 to 3 waveforms. If you have got a good flow, you will get umbilical artery waveform above and the venous waveform below. And you want to measure the umbilical artery waveform and plot it on your nomogram. Now, we come to the third important vessel. Again, Dr. Bija is going to tell us the importance of this in reference of fetal growth restriction in a short while. Let me see. So what I'm trying to do here is I'm looking at fetal head, taking an axial section, going down to the cerebellum, and I can already see pulsatility over here. The video is a bit smaller, but you'll see that there is pulsatility there. This video will not run, so I'm going to skip that. But what I'm going to do now is put color on the fetal brain. So you can beautifully see the circle of Willis and the branch which is coming directly in the direction of the probe, which is your middle cerebral artery. You choose the appropriate gate size. And here it is very, very important that you keep the gate size 2 millimeters. You sample it just outside the circle of Willis in the direction of the flow so that your peak systolic velocity, which is an indication of fetal health, especially if you are trying to diagnose fetal anemia, is absolutely accurately pulsed and sampled. Because if you are turning your angle away, you do not only lose the peak systolic velocity, you actually falsely miss out on anemias because your velocity reduces. So please make sure that you sample this exactly in the direction of the flow. The angle should be as close to 0 as possible and never beyond 30 degrees. Moving on, let us see how it works in real life. So here I have a fetus who is cephalic. All right, this is a breech baby. Yeah, that's a breech baby. So I'm going up there. Now, breech babies for any Doppler, especially cerebral artery, would pose a particular challenge because the head will move with mother's breathing. And that is why sometimes when you're taking Dopplers, you want to tell your patient to hold her breath for just a second. So here we are. I'm magnifying the head appropriately. I'm tilting my probe 30 degrees so that I get to see the base of the skull where I have got circle of Willis. Now, when you see the circle of Willis, you put the color box on. And nowadays, you've got advanced machines which will do all of this job very easy for you. You just tell the machine that I'm looking for MCA Doppler. It will adjust the PI and the colors such that the MCA Doppler pops out, boom, on the screen. Now this patient is breathing, and that's why you can see there is disturbance in the color. Now we'll request her to hold her breath for a second. And I'll sample it now. So that's the sample. I'm trying to adjust my angle. And then I look at MCA PI and MCA PSV, give those values to Dr. Bijoy for further interpretation. Now we come to the last and important Doppler, which is of course ductus venosus. We know that it's a tributary going into the inferior vena cava in the liver, and it indirectly reflects the function of the heart. So in cases where this function could be compromised, this sample is going to reflect on it with increased in the resistance, which means that if you are looking at this graph shown by the cursor, the red line above, which is 95th centile, will be crossed by the ductus venosus PI. So again, like any other vessel, you want to locate it, you want to put color on, and then you want to sample it. I think this video is not working. We'll directly go to the sampling video. It's very, very easy, and I'll show it to you in 1 second how it works in real life. So here we come. So again, we are in the axial section for the fetal abdomen. I can see that the umbilical vein is coming. It's climbing up, and now it will turn into a crescent. Just before that, you see a ductus venosus going up over there towards the heart. This is the best place to sample ductus. Mind you, the method of sampling of ductus in first trimester is quite different and much more easier. And that is the reason why I've skipped on that and I've just taken this. So you go to this level, you see that the umbilical is turning. It is giving this red looking aliasing waveform, which is reflecting high velocity, which is our ductus. I'm going to adjust it appropriately, sample it. And as you know, in the first trimester, a ductus venosus Doppler is also one of the markers for trisomies, especially trisomy 21. That's the waveform which is giving me a PI. I'm seeing a nice presence of A wave, and I know that I'm looking at a healthy baby. I'm going to stop over here with the technique. As we discussed, we need to be aware of use of Dopplers, limitations of Dopplers, and when to avoid them. What we call as low as reasonably possible, ALARA principle. Uh, with this, I'll take your permission, Dr. Asha ma'am, and the August audience here, and I'll hand it over back to you. Thank you so much.
Thank you, sir, for that very elaborate talk. It was very useful to beginners like myself. I request Dr. Ritu to add a few words. Ma'am, would you give a few concluding remarks, ma'am? Dr. Ritu? I think ma'am is not here.
Yeah, ma'am is here. Ma'am is here. Ritu ma'am, you have to unmute yourself, please. Yes.
Yes.
Yeah, ma'am, yeah, please.
It's very good presentation, ma'am. Hello.
Yes, ma'am, you're audible,
Yes,
ma'am.
ma'am.
Please.
Hello. It's very useful for me also. I am just beginning and learning in this Doppler. So it's very useful and very good presentation by Dr. Omarji Chinmay sir.
Great, madam.
Overall,
Thank
it's
you.
very.
Thank you, Dr. Chinmay. I know that was, I think like a PhD teacher teaching kindergarten's kids. But still, even that is necessary at some point. Because, once people start with that, they're going to grow.
So true. So true.
So thank you for being, so patient and explaining everything. Thanks a lot.
Thank you.
Thank you. So we go forward to the second lecture. Bijay sir has joined in. So, Sujya?
Yeah, sure, ma'am. Yeah, so we will begin the second session for today, and the topic is interpretation of Doppler findings in singleton pregnancy. So I would like to introduce the chair for the second session. So we have Dr. Om Sheila Gulia with us. She is the president of Bhiwani Obstetric Gynec Society, life member of ISAR, IMA, and IMAAMS. Madam is a senior consultant with 30 years of experience in private practice in obstetrics and gynecology. We welcome you, ma'am, to today's session. Next, we have Dr. Uma B. Deshmukh, ma'am. Ma'am is the HOD of Department of Obstetrics and Gynecology in Bidar. Madam is also a member of the advisory committee of PCPNDT Bidar District, nodal officer for maternal mortality Bidar District. Madam has also been the IMA vice president in the year 2022. She is the current president of Bidar Society, executive committee member for Women Doctor Wing. So Madam has received a lot of awards. So we're very grateful to you, ma'am. You've accepted our request and you're here with us today.
Thank you. Thank you, madam.
Our pleasure, ma'am. Next, we have Dr. Harshad Ruprela. Sir currently is the director of Ruprela Diagnostic Center in Raipur. He's the state vice president and central body executive member for the Society of Fetal Medicine. Sir's academic qualifications are, he's done his DNB radiology from Mumbai and DMRD. Sir has numerous publications and awards to his credit. He has received the best oral poster presentation in National Neurology Conference, which was held in Mumbai in 2012. And his areas of interest are fetal growth in Doppler, fetal echocardiography, vascular limb Dopplers, and endoanal ultrasound. So we welcome you for today's session. I request one of you to please introduce the speaker for today, Dr. Bijay K. Balkrishna, sir.
Hello.
Yeah, ma'am, please. Proceed, ma'am.
Good evening, everyone. Thank you, Dr. Asha, for inviting me such an important webinar on such a useful topic. Let me have the slide of today's speaker, please.
Ma'am, the slide is visible, ma'am.
CV?
Yeah, ma'am, the slide is visible, ma'am. It's on.
This is about Dr. Bijay?
Yes, ma'am.
Yes, ma'am.
Dr. Bijay Balakrishna is graduated from Karnataka University in 1999. He is MS in Obs Gynae, is head of FM unit in CIMAR since 2007. He is president of Kerala chapter of SFM. He is invited speaker in various conferences, national and internationally. He is winner of Kalyani Devi Award for Best Paper. He is organizing secretary of Pericon series and SFM 2014. He has many publications in various journals. He is practicing fetal medicine for last 15 years, well versed in all fetal medicine procedures, amniocentesis, CVS, and shunt procedures, fetoscopy, etc. Welcome, Dr. Bijoy Balakrishna. He will speak on today the interpretation of Doppler finding in singleton pregnancy. Dr. Bijoy, please.
I must thank Dr. Asha for giving me this opportunity here. And I'm sorry I cannot come on live because I'm commuting from work. But I've already sent in my recorded presentation to Dr. Asha, and I'm sure she'll be presenting it now. So sorry for not being able to come on live, but I'll be here to answer any queries after.
Sure, sir. We'll go ahead with the presentation.
This is it?
Yes, ma'am.
So thank you, Bijoy sir. So I will be playing this and sir is around for any questions.
Be here. I'm going to talk about Doppler interpretation. Good evening, everyone. Let me start by thanking Dr. Asha for giving me this opportunity to be here. I'm going to talk about Doppler interpretation in singletons. When we talk about Doppler and when we talk about interpretation specifically, what are we interpreting? What are we assessing? When you look at any vessel, for that matter, let it be any vessel, we are looking at two basic components of that vessel. The first component being the systolic flow, and the next component being the diastolic flow within that particular vessel. So the systolic flow will tell us the status of the pump or the heart, whereas the diastolic flow will tell us what is the condition of the end organ where that particular vessel is supplying. So if you know where a particular vessel is ending, automatically you will know whether that vessel is ending into a good organ or not. For example, let us look at these vessels. The uterine artery ends in the placenta, so the diastolic flow will be representative of the condition of the placenta. The umbilical artery will be representative of the condition again of the placenta. The middle cerebral artery of the fetal brain, the ductus venosus of the fetal heart, the aortic isthmus of the fetal peripheral resistance, and the umbilical vein of the fetal heart. So if you know where a particular vessel is ending, and if you know the condition of the diastolic flow within that vessel, you will be able to predict the peripheral resistance in that end organ. So that's what we are trying to assess. For that, we have a number of tools like angles and ratios, which are very important in assessing blood flow through a particular vessel. Now, there are a number of ratios that are used, but the one that all of you should remember is the pulsatility index. Pulsatility index is what is used nowadays to assess Doppler flow across vessels, and that's because when the diastolic flow becomes zero, it's only the pulsatility index that will give us some meaningful value. Now, having understood that, let's look at these vessels one by one. The first one being the uterine artery. The uterine artery is the maternal supply from the mother into the uterus, and it supplies the placenta, the maternal compartment of the placenta. And as the gestation progresses, the resistance within the uterine artery drops, the perfusion increases into the placenta, and the placenta becomes larger and more healthier as the gestation progresses. Now, it's an important screening tool because if the supply is not adequate, it tells us whether the placenta is normal or not. So if the supply is bad, the placenta will not be able to function normally. But it assesses the maternal compartment of the placenta, mainly the spiral arteries which come off the uterine artery, supplies the maternal compartment of the placenta. In fact, the placenta is a two-compartment organ with a maternal side to it and a fetal side to it. The maternal part is supplied by the uterine artery and the fetal part is supplied by the umbilical artery. If you look at the placenta, it's got a very unique structure wherein you have cotyledons that are swimming in pools of maternal blood. These pools of maternal blood are supplied by the uterine artery, and the cotyledons themselves are supplied by the umbilical artery. Now, whenever you get a bad placenta, you can get either of these following conditions. You can have either an abnormality both in the umbilical artery and the uterine artery, or you can have an abnormality in either one of these vessels, either the uterine artery or the umbilical artery. The best example would be APLA and late onset FGR. In antiphospholipid antibody syndrome, you will find that the uterine artery is completely normal, but the umbilical artery is abnormal. It's because the supply is good, the maternal sinuses are well perfused, but because the placenta has got areas of ischemic necrosis, there is going to be an abnormal fetal compartment of the placenta, leading to growth restriction, leading to preeclampsia, and also it is because of these focal areas of ischemic necrosis, you're going to get an abnormal umbilical artery diastolic flow. Whereas in late onset FGR, the placental damage is not very significant. The fetal compartment of the placenta is not damaged significantly, and therefore the umbilical artery is going to be normal, but the supply from the mother to the placenta might be abnormal, giving you an abnormal uterine artery but a completely normal umbilical artery. Now, to assess whether the uterine artery is normal or abnormal, we don't go by a subjective assessment. That is, we don't look at notching and seeing whether the notching is present or absent. Instead, we take again a single value of the pulsatility index. And if the pulsatility index is greater than the 95th centile for that particular gestational age, we say that the uterine artery PI is high. The best time to assess it would be either the first trimester if you're screening for preeclampsia and FGR, and also in the second trimester if you want to screen for late onset FGR or FGR that can develop later on in pregnancy, or also for preeclampsia. But when you have a small baby in the third trimester, you can look at the uterine artery to see if the supply is good, and if the supply is not good, then you can say that that baby is small because of restricted supply from the mother into the maternal compartment of the placenta. But we do not usually look at the uterine artery if you have a flank abnormality within the umbilical artery, because if the umbilical artery is abnormal, we already know that this baby is small because of a pathology within the placenta. The umbilical artery, on the other hand, supplies the fetal compartment of the placenta. Now, as the gestational age advances, the resistance within the umbilical artery drops. Now, here an important caveat of the umbilical artery is that if the placental damage is less than 30%, then the umbilical artery will not show an abnormality. So there has to be severe placental damage above 30% before you can see an abnormality within the umbilical artery. And the umbilical artery usually shows this kind of a flow pattern with good diastolic flow, which keeps on increasing as the gestational age increases. Here again, we are going to look at the PI values and not absolute subjective assessments, except in certain conditions. If the PI is high and there is still diastolic flow, we assume that the placental damage is around 30% and above. But if the placental damage is above 60%, then the diastolic flow disappears, and this condition is called as absent end diastolic flow. If the placental resistance is in the form of a reversed end diastolic flow because 70% of the placenta is damaged, then you know that the placenta is really bad. So usually we look at PI values for the umbilical artery, except in the cases of absent end diastolic flow and reversed end diastolic flow, because here we know that the diastolic flow is absent, the PI is going to be extremely high, and these are direct triggers telling us that probably this placenta is really, really bad. So normally we use charts and we don't use single cutoffs, and if it is greater than the 95th centile, we say that the umbilical artery is abnormal and the placenta is bad. We have to take multiple readings before we say that the umbilical artery is abnormal, because sometimes due to fetal movement or sometimes due to mild compression of the cord, you can get increased resistance, and therefore you have to take multiple readings before you confirm that the value is actually abnormal. Now, it's an excellent tool in doing serial prediction for FGR, serial follow-up for FGR, and also to make the diagnosis of FGR. It is currently recommended to be used only in growth-restricted fetuses and preeclampsia, but that is probably going to change soon, and we're going to look at the umbilical artery and the middle cerebral artery for all fetuses whenever we have a growth scan. The middle cerebral artery is a vessel that tells you directly about the fetal status. So it's basically used to assess for fetal hypoxia and also for fetal anemia. In hypoxia, when the blood supply to the brain decreases, chemoreceptors are activated and causes a dilatation within the middle cerebral artery, leading to what is called as the brain sparing effect. Whereas when there is anemia, blood is going to become thinner, less viscous, and therefore it is going to be pushed faster. And this high speed of the blood flow can be easily assessed by looking at the middle cerebral artery. So in hypoxia, we look at the PI of the middle cerebral artery, and when there is a drop in resistance, we know that there is hypoxia. And in anemia, we try to look at the velocity of blood flow within the MCA, which is basically the peak systolic velocity. And if it is high, we know that there is fetal anemia. So here again, we're going to look at ratios when we're concerned about hypoxia. And if the MCA-PI is less than the 5th centile, we call it possibly chronic hypoxia. But if the MCA-PSV, that is the velocity, is greater than 1.5 moms, we call it anemia. And if the MCA-PSV is less than 1 mom, which means the blood is more thick, more viscous, then we call it a probable polycythemia. Now, an easy rule of thumb to remember if the MCA-PSV is greater than 1.5 moms is to rely on this basic mathematical tool, which is basically knowing the gestational age and doubling the gestational age. If the MCA-PSV value is twice the gestational age, then you know that you're dealing with possible anemia. For example, a 20-weeker, if that 20-weeker has got an MCA-PSV of above 40, then we know that that fetus has got anemia. So the best time to assess an MCA-PSV or an MCA-PI, as I've already told you, PSV for anemia and PI for hypoxia. So if the mother is ICT positive, we follow up these fetuses by looking at the MCA-PSV. And if you suspect FGR, especially late onset FGR, then we look at the MCA and try to see if the fetus has got hypoxia. The middle cerebral artery has got no value in early onset FGR. It's only used in late onset FGR. Now, the problem with the MCA is that it becomes late, it becomes abnormal pretty late, and therefore it sometimes does not pick up hypoxia until the gestational age has progressed a lot. And therefore, it's important to look at this particular marker, which is called a CPR or cerebroplacental ratio. Now, what cerebroplacental ratio does is that it allows us to pick up hypoxia even before the MCA or the umbilical artery becomes abnormal, and it is a very sensitive marker for hypoxia as compared to the MCA. For example, if you look at this chart, you can see that the umbilical artery, these blue dots showing the umbilical artery PI, is below the 95th centile, and the MCA is above the 5th centile. So essentially, these two values are normal. But when you look at their ratio, which is the ratio of the PI of the MCA divided by the PI of the umbilical artery, you will find that it is 1.2, which when you put into a CPR chart will tell you is pathological because it is less than the 5th centile. So here again, we are going to use charts. We'll calculate the CPR and use charts that will tell you what the CPR value should be for that particular gestational age. And if it is less than the 5th centile, we call it abnormal. So the CPR tells us that there is a possibility of hypoxia. It raises your index of suspicion of hypoxia and tells you that these fetuses need more frequent follow-up. But an abnormal CPR or an abnormal MCA is not an indicator for preterm delivery in FGR. They are not triggers for delivery. They are just telling you that there is hypoxia, this baby is compensating, and therefore needs more frequent surveillance. And that's why we need a trigger for preterm delivery. And that trigger for preterm delivery is not the CPR or the MCA, but the ductus venosus. And the ductus venosus is a vessel that flows into the heart. It is a precordial vein of the fetal heart, and it functions exactly like a JVP would in the adult heart. So when the pressures in the right heart increases, there will be an abnormality within the DV flow. That is, the DV pressures will rise and tells you that the right heart pressures are also high. So it's exactly mirroring the pressure changes that are happening in the right side of the fetal heart. There are a number of methods by which you can assess the ductus venosus, but what we usually prefer is this method, wherein we take an axial section of the abdominal circumference and slightly tilt our probe upwards so that we can identify the ductus and then take the ductus venosus waveform. Now, the ductus venosus waveform is different from the waveform that you saw up till now. Up till now, you saw a biphasic waveform, and here you have a triphasic waveform with three parts to this waveform, with a systolic part and a diastolic part. Whereas in the other patterns that you saw a clean S wave and a D wave, but here apart from a D wave, there is what is called as an A wave. So the diastolic flow within the ductus venosus is divided into two parts. The first part being the capital D wave, which is also called as the early diastolic flow, and the second part, which is depicted by the small A wave, is depictive of flow happening in the later part of diastole, which corresponds to the event that takes place in the heart, that is atrial contraction. So when the AV valves open, there is passive flow of blood from the atria to the ventricles, that is denoted by the capital D wave. And as soon as the atria contracts, again blood is pushed from the atria into the ventricles, leading to a sharp decrease in flow in the ductus venosus, and that is denoted by the small A wave. So if you look at the heart, the same thing is seen across the tricuspid and the mitral valves in the form of an E and an A wave. So the E wave corresponds to the diastolic flow in the first part of the ductus venosus flow, which is the D wave, and the A wave corresponds to the smaller A wave. Now, it is a marker for right heart failure. So if you have acidosis, that is when the pressures will increase within the right atrium, and when the pressure increases within the right atrium, the DV will be able to pick it up. So when the DVPI is high, it means if it is greater than the 95th centile, there is a low suspicion of acidosis. But when the DV reverses, there is a high suspicion of acidosis. Currently, it has been accepted that if the DV reverses, it is a trigger for preterm delivery in early onset FGR. The DV can also be used for screening for aneuploidies and congenital heart diseases. In the first trimester, if you find that the DV is reversing, or if you find that the A wave is absent, there is a strong possibility that there could be a congenital heart disease, or the fetus could have aneuploidy. The DV can also be assessed in certain arrhythmia conditions like supraventricular tachycardia, where if the mother is being treated to improve the cardiac status of the fetus, one of the methods to monitor whether the treatment is working or not is to look at the DV, because one of the first signs of adequate treatment for SVT is the reappearance of the A wave in the ductus venosus. It is also used to classify and stage fetuses, monochorionic fetuses with certain complications like TTTS. The next vessel on the list is the aortic isthmus. Now, as aortic isthmus is supposed to be a prognosticating marker for neurological morbidity in FGR. It's still under research, but it's worthwhile to know what this vessel is telling us. The aortic isthmus is the junction between the aorta and the ductus arteriosus, and normally you will get forward flow both in systole and diastole. But if the pressures within the brain are less and the pressures in the umbilical artery are high, or within the placenta are high, then you will find that blood, instead of going forward, will start to go through the aortic isthmus back into the brain, and that is what is called as aortic isthmus reversal. So basically, it is another method to assess brain sparing, because the pulmonary artery supplies the ductus and the ductus supplies the placenta. The aortic isthmus will come and join the ductus arteriosus. When the pressure in the brain drops and the pressure in the umbilical artery rises, then the duct, instead of pushing blood into the umbilical artery, will push it back into the aorta, and that's where you get aortic isthmus reversal. So this is how it will look in a normal heart, where there is still forward flow in diastole because the pressure in the brain is high. There is no brain sparing reflex here. But in the case of FGR, you can clearly see that there will be reversal of flow or increased flow during diastole in the direction of the brain, which means that there is brain sparing effect. That can also be seen here, where you can see there is good amount of forward flow both during systole and diastole. And when you place your cursor exactly at the point where the aorta meets the ductus arteriosus, this is the kind of wave pattern you're going to get. Coming to the umbilical vein, now umbilical vein is not a vessel that is used routinely in clinical practice, because it's the vessel that will show an abnormality just before the baby is going to die. And that is not something we will usually wait for. Normally in the umbilical vein, you will have straightforward flow, which is non-pulsatile, but towards term, you will find that there will be sort of an undulation that can be seen on the umbilical vein, and that is usually because of fetal breathing. And that is called as the monophasic pattern that is seen in the late gestational ages. But if you see a biphasic or a triphasic pattern within the umbilical vein, it's always abnormal, which means the umbilical vein is now mirroring pressure changes that should be seen only in the ductus. And therefore, it means that the heart is in really bad shape and it is the penultimate stage before the fetus actually dies. But having said that, always the fetus does throw in certain surprises. For example, if you look at this umbilical vein pattern on the left hand side, you can see that it is clearly biphasic. And on the right hand side, I've shown you a normal umbilical monophasic pattern that you would see in later gestations, like around 34 weeks. This is basically because of breathing. But if you look at this pattern that you can see on the left hand side, you can see that there are clear-cut pulsations seen here. So does this mean that this baby is going to die? When we did a closer evaluation of this fetus, we found that this umbilical vein was actually entering into the umbilical artery, creating what is called as an umbilical artery umbilical vein fistula. And because of this fistula's connection, the pulsations within the umbilical artery were being mirrored in the umbilical vein. And that's why this baby was not going to die immediately, but had the possibility of developing cardiac overload and possibly hydrops because of an AV fistula. And that's basically the most important thing about Doppler. It is the language of the fetus. It is the way the fetus is going to speak to you. And although we do hear it, we don't understand it. And when we don't understand it, we try to just follow our instincts, and that misinterpretation can be catastrophic for the fetus. And therefore, the only option for us is to not only to learn how to take and measure these vessels and their diastolic flow, but also to understand and interpret them. Thank you. Thank you so much for listening.
Thank you, sir. That was a very informative talk. And I was actually jotting down a lot of notes. It was really very informative for beginners like us. So I would request the chairpersons to please give concluding remarks about this talk. Ma'am, Dr. Uma, ma'am.
Hello.
Yeah,
Really, this is a very much informative talk, and many things we came to know first time, and it is the best presentation for the beginners like us. And thank you very much, sir.
Thank you. Thank you so much. Yes.
Dr. Uma, ma'am, would you like to add something? Dr. Uma Deshmukh, ma'am.
Yes, just now I have. Hello.
Yes, ma'am. Yeah, ma'am. You're audible, ma'am. Ma'am, would you like to say something, ma'am?
No. Everything sir has told. Thank you very much.
Fine, ma'am. Thank you so much.
Harshad, would you like to add something?
Hello.
Yes,
Yes,
Dr.
sir.
Harshad. Yeah,
So you're audible, sir.
One second. I'm audible?
Yes, sir, you're audible, sir.
Yeah. Hello, Bijoy, sir. Your lecture was really very nice.
Thank you.
Thank you. Sir, I just wanted to ask you one thing. It's already covered, I know, in most of the lectures, but then I see multiple cases where we see in late onset IUGR, especially in late onset IUGR, everything is normal. We do a Doppler, we have done a Doppler, like say 2 days back or 1 day back, and everything is normal. The MCA Doppler is normal, the umbilical is normal, but there is an IUGR because there's a deacceleration of growth. That's how we say that there's an IUGR in this child. And it's not a constitutional delay. But then, I have followed the 1 or 2 in the 7 years of my practice. I have seen once or twice that there is a sudden death of this child because we are planning to take that child for delivery, but then before that only the child dies. IUD is there. So why this happens in late onset IUGR, and how can we predict that like this is going to happen with this fetus?
Let me get that question correctly. You're saying that there was a drop in growth velocity, but
Yes.
there were no findings on Doppler. Am I correct?
Exactly, sir.
Okay. So when you see a drop in your growth velocity, and if you're not finding any changes on Doppler, I'm assuming that it's because you're finding a normal MCA, normal umbilical artery, and a normal CPR.
Yes.
Okay. So the problem here is that the hypoxia in these conditions might be very subtle to be picked up by the vessels themselves. And therefore, that's why it's important, like for late onset FGR, our monitor should not be just based on Doppler. It should be a combination of Doppler, biophysical profile, and your CTG. So if you're suspecting late onset FGR in a fetus that is having a drop in growth centiles, but is still above the 10th centile, or let's say above the 25th centile, and you're monitoring these patients, you cannot monitor them just on the basis of Doppler. You have to use your biophysical profile and your CTG. And sometimes you might have to do it almost every other day, especially if you find that the CPR values are dropping. They might not become frankly abnormal, but they may be dropping. So if you find a negative trend, both in terms of growth as well as in your CPR or MCA, then you have to be on your toes and you have to put these patients on careful surveillance with biophysical profile.
Hello.
Sir, you've muted yourself.
Basically, the
Sir, you've muted yourself.
I'm sorry, it's because I'm traveling.
Yeah. So you're audible now, sir.
Yeah. Okay. So I hope that was clear.
Sir, the last part, what you said was not audible.
Yeah, hello. So I just want to conclude on your answer. So
Yeah.
just summarize what I have understood is that if there is a late onset IOG, because in early onset we generally see the changes in the in the umbilical and MC, and we can predict that.
Yes, you will.
Especially we have main problems in late onset IUGR when I am not able to answer the gynecologist since I'm a radiologist. So should we take a call to deliver or to wait and let the maturity happen? So if we have to, even if the MC umbilical is normal, we need to follow on the graph, like on the centile also. That's what you mean
Yes,
to say, sir.
yes.
And
Also, if you
even
find
the
there is a
biophysical
problem,
profile becomes important here.
yes, it becomes very important, very important.
Okay,
Because then you
okay, sir,
know
I
that
got it.
there is some amount of hypoxia, and this hypoxia may be strong enough to suppress the brainstem.
Okay, I got it, sir. Thank you so much. That was really
Sir,
nice, sir. Thank you.
missed beats are common in fetal cardiac.
Pardon? Missed beats in. I didn't get you.
Yes. Yes.
So if you see a missed beat, okay. So if you see a missed beat, the most common cause is going to be a premature atrial contraction rather than anything else. And if you have to just assess the heart and see if it is actually a premature atrial contraction or not, and if it is not occurring very frequently.
Hello.
Yeah, I'm sorry, I'm losing connection. I'm sorry.
Yeah, so can you just repeat what you said? Yeah, just.
I said if it is a missed beat, all you have to do is to see its frequency. If it is very frequent, that is, it is happening like more than 1 or 2 times in a 10-minute trace, then maybe you have to probably keep the patient under surveillance. But if it is very occasional, then you can leave it. Usually nothing will happen. So it's the most common cause being a premature atrial contraction.
And usually late this one will find asymmetric this one, no, IUGR.
In missed beat, no, not necessarily. There is no relationship between IUGR and missed beats.
Sir, is the missed beat, occasional in 10 minutes trace, or it is about 5 per minute trace?
No,
if you 5 per 1 minute.
No, it's like if it is present for more than half of your examination time, which is 10 minutes. If you find that it is occurring very frequently in a 10-minute period, then you have to be worried about it. If you have just one ectopic beat once every 10 minutes, then you don't have to be worried about it, which means like for your whole examination period, you might find just two beats. So that's a rough ballpark figure on how frequently if it occurs, it's going to be a problem.
Okay, thank you, sir.
I'm sorry about this. I cannot because I'm traveling.
Thank you, sir.
Yes, thank you. Thank
Sir
you.
is my teacher from Gynec Academy, and I'm really honored to have him here with us and sharing the knowledge that he has shared with us with everyone. Thank you so much, sir.
Thank you. Thank you so much.
We will now proceed to the final part of today's session, which is the panel discussion. The topic is obstetric cases with Doppler, highlighting the management as per guidelines. So Dr. Asha ma'am will be moderating this session. We have experts. Dr. Mehul, could you please share the screen?
I'm trying, but somehow I'm not able to share that.
Okay, I have it. Yeah, it's there. So we have experts, Dr. K. Chellappan sir, who's presented numerous papers in national and international conferences. He's done his diploma in hospital administration from New Delhi. He's been trained in ultrasound and color Doppler in various centers in India and abroad, like Singapore, Seoul, Hamburg, and Cagliari. He's also been trained in laparoscopic and hysteroscopy from various centers. He's been trained in colposcopy techniques. He's the member of FOXI, IAG, IFUMB, ISAR, ISPAT, GSI, Endometriosis Society of India, ISCCP, SFM, Thalassemia India, IMA Rotary Club of Bharuch. Sir has been the member of international bodies like ISCOG and ISGE. He's presented papers in national, state, and local conferences. Sir has special interest in preventive care in women. He's been practicing for the last 2 decades as a general OB-GYN at Bharuch. Sir, we welcome you to today's session. Next, we have Dr. Anu Joseph. Ma'am is the medical director and senior consultant at Trinity Healthcare Clinic. She's also the senior consultant at Kaveri Hospitals, Bangalore. Ma'am is the founder member and executive committee member, Society of Maternal Fetal Medicine, member of the Society Fetal Medicine, executive committee member of Karnataka chapter. She's also the member of BSOG and FOXI, event coordinator of virtual learning series, organizing committee member of ISSHP 2023 conference, and team leader for paper and poster presentation. She's conducted and presented in various CMEs on obstetrics and fetal medicine. Her special interests are early pregnancy screening and risk prediction. We welcome you to today's session, ma'am. We're looking forward to valuable input from both the experts. I will now introduce the panelists for today. Yeah. So we have Dr. Chintan Thakkar. Sir is the president of Bharuch Obstetric and Gynaec Society. We have Dr. Manish Trivedi sir with us, who is the president of Bhavnagar Obstetric and Gynaec Society. Dr. Dhaval Kumar Patil, who is the secretary of Anand Obstetric and Gynaec Society. Dr. Swati Tyagi Bharadwaj, ma'am is the secretary of Bhivani Obstetric and Gynaec Society. Dr. Puneet Khatri sir, he's the president of Bhuj Obstetric and Gynaec Society. We have Dr. Bhavik Khatri, I think they're related. Sir is the secretary of Bhuj Obstetric and Gynaec Society. Dr. Rameshwari Malshetty madam, she's the secretary of Bidar OB-GYN Society. Dr. Purvi Agarwal, who's the executive member of SFM Raipur. We welcome all the panelists for today's session. I now request Dr. Asha ma'am to please proceed.
Thank you so much. So now we have all the basics ready. We have our experts with us, and we also have the panelists. So we are going to have certain situations that we are going to discuss. And according to those situations, we as gynecologists, what is going to be our course of action is what we are going to talk about. We all know Dr. Sujayshri, who's the convener here. The co-convener is Dr. Sameer Kathale, who's the secretary of SFMCG. He's a consultant radiologist. He's the only one who hasn't been properly introduced. So welcome, Sameer. He has life membership of ISWAG, SFM, FMF, IRIA, ICRIA, IACI, MNAMS, MANBD, and IMA. And his areas of interest are fetal radiology, including fetal-maternal interventions, fetal echocardiography, interventional radiology, musculoskeletal radiology, and cross-sectional imaging. So we will start. This is again, I think, the wrong presentation.
Yeah, I would request all the panelists to please mute their phone. There seems to be a lot of disturbance. I request everyone to mute their phones for now.
Dr. Divyesh Patel sir, HCG Mati.
We have the panel on obstetric Doppler, and I request all of your support for
Food, Drug and Medico-Surgical Equipment Committee, FOXY. The election will be in August. All our experts have been introduced, and this is a very short slide on which Doppler test, which test to do when to do umbilical artery and mean uterine artery PI, what else. So this is what is available on the net easily. I have already shared the link, and I'll also put the link in the YouTube box, but we will now directly go to the situations. So here is case 1. She's a 22-year-old, Gravida 1. Her BMI is only 17. She came at 12 weeks for anomaly level 1 and NT scan. The CRL was 59 millimeters, NT was 1.5 mm. The ductus was normal. There was no tricuspid regurgitation. Sorry for the spelling. No anomaly was identified in the current scan. The combined screening was sent as a part of normal screening. Her PAPA levels were low, the HCG was normal, and the PLGF was normal. So, a very basic question, what does a low PAPA indicate?
A low PAPA, if it is less than 0.6 MOMs, it can be predicted. On one side, trisomy 21 fetuses do show low PAPAs, less than 0.4. But independently, when only PAPA is low, it can be indicative of preeclampsia. It is one of the screening for preeclampsia prediction.
What about growth restriction?
Placental pathologies as a whole. So preeclampsia and fetal growth restriction.
So now how are you going to follow up this patient? All my panelists are please requested to put on their videos, and anyone can answer. Anyone can answer.
Can I answer, madam? Dr. Dhaval?
Yes, sir. Yes, sir. Sir, please, camera chalu kar lijiye. Yes, sir.
Madam, right now I'm in my hospital, so doing some OPD work there, so it's not possible to camera on.
Okay.
But I will answer this thing. See, in this case scenario, there basically all things are normal except Papa, right? And the Papa value is 0. It's a rule of thumb, the 0.5 mom, this magic number. If the value is less than 0.5 mom, the chances of PIH and IUGR is high. That means the placenta, something is worse or any bad sign in placenta, right? So my next concern is the uterine artery status. Does it uterine artery status in first trimester is normal according along with the Papa value low Papa value?
The PLGF is normal. The uterine Doppler is also normal.
Okay, then nothing to worry. Then we will do the anomaly scan at around 20 to 22 weeks. Again, reassess the whole fetal environment, placental Doppler, that means uterine artery, and is along with the umbilical artery. If the uterine artery is high resistance flow, then means according to rule of thumb is more than 1.5, 1.4. More than mean arterial PI is more than 1.4. That means there is a chances of PI is early IUGR or something is wrong, bad placental thing is high. So this baby I will keep put on the surveillance, and we'll do the growth scan at 28 weeks and 36 weeks at Doppler.
Okay. You want to do it at 2-month interval?
Sorry, madam?
Means you want to do at 28 and then directly at 36?
28, 32 and 36.
Yes, Dr. Anu?
Provided the 28-week scan is quite normal. There is no IUGR set in, the PIH is not set in, and the Dopplers and the AFI have been fine. But otherwise, it is worthwhile to do a monthly 4-weekly scan for the patient.
Dr. Chintan, would you like to say something?
Ma'am, I'll agree to Dr. Anu. Since there is one value which is showing, am I audible?
Yes, sir.
There's one value which is showing, some abnormality. Then probably we have to be slightly more vigilant regarding the early onset IUGR. And that is, we need to check the fetus, particularly for growth and Doppler every 4 weeks.
Okay. And
every 4 weeks or every 15 days?
No, ma'am, growth within 15 days is not going to be of much use. If you see that at 28 weeks, there is a growth restriction setting in, or the fluid is low, or the Dopplers are not looking very normal, then you can call her back at 2 weekly interval for her Dopplers. But growth at 2 weeks may not be appropriate.
okay, is there any role of CTG?
CTG will not be very useful or conclusive before 28 weeks of pregnancy.
So after that, we are talking about the entire pregnancy.
Okay.
So means in
according
the
to me,
first trimester, we have detected that she has low PAPE. So now, how is she going to be followed up broadly? Are you going to do all 4 vessel Doppler? Are you going to do growth scans? Are you going to do a biophysical profile and CTG?
as far as what I would consider is the biophysical profile and CTG. They are more for neurological integrity of the fetus, as well as whereas the Doppler findings, they are more indicative of cardiovascular integrity. So whenever there is an early onset FGR, it puts more burden on this cardiovascular things, and that's how our Dopplers are more indicative. So if I'm doing 28 weeks, the follow-up scan, and if the baby is the fetus is showing the signs of fetal growth restriction, I'll put it under the category of early onset FGR, and then I'll follow that fetus up with the Doppler vascular Doppler. If up to 32 weeks the baby fetus is showing normal things, and then the growth shows slightly lacking, and then it would be in the category of late onset, and that fetus I would be more focusing on biophysical profile as well as CTG.
Thank you, sir. That was a very important point that you brought out, that in the early growth assessment, you want Dopplers, and in the late, you have to add your biophysical profile and CTG. So I think we are done with this. And now this is case number 2. This is about the risk for preeclampsia. She is a 33-year-old gravida 1, and she has conceived with ovulation induction. She has presented for the first trimester scan. Now the CRL is 62, NT is 1.8, DV normal, TR absent. Uterine artery mean PI is 2.8. In the combined screen, the PAPE is 1.1, HCG is 1.8, and the PLGF is less than 0.5. So what comes to your mind looking at this report?
In this case, madam, the uterine artery PI is high, the 2.8 is more than 1.4, and the PLGF is also low. That means there is chances of early FGR, and the preeclampsia before 32 weeks is higher setup. So I start with the prophylactically aspirin 150 milligram 1 HS up to 36 weeks, and put this fetus in on surveillance. Means after anti-scan, I restart that rescan. This patient is 18 weeks, and see the again Doppler's umbilical artery along with the uterine artery, and overall the early target scan I want to did these things.
Chintan sir, I wanted to ask you that would you give aspirin alone, or do you want to add heparin, or you want to give only heparin? What would be the practice in your area?
Madam, I would start only aspirin. Low molecular weight heparin we give to those confirmed cases who are having lupus anticoagulant positive
Autoimmunity.
and autoimmune problems. For those who are having prediction of FGR or PIH early onset, we'll go with aspirin, that is acetyl salicylic acid.
You would go with 150 milligram?
150 milligram, one at bedtime.
Okay. See, these are things that I have seen in my practice, so I bring it up. Do you see any role of IgG?
No, ma'am.
No.
No,
It's
ma'am.
just empirical, madam. It's just empirical and prophylactically used only, because there is no any role of any Bhaglob and heparin until unless any evidence.
Okay. So now, Chilappan sir, we want to bring you in. If you would like to say something about ophthalmic artery Doppler.
Recently, there have been studies on ophthalmic artery Doppler, and last year also in Foxy Journal it has come. Our Medical College of Baroda has done an extensive study on this. But personally, I have no experience on this. And clinically, I think it is just a surrogate marker. If you have done your uterine artery Doppler properly, then there is the clinical practice, ophthalmic artery Doppler has a limited role. You need an additional transducer, the high frequency or 9 to 11 you need. Secondly, you'll have to counsel the patients that you're going to be insonating on the eye. So all those things would need, I mean, in our practice, it will need some more time to get acclimatized to. But there are definitely some studies recently which have indicated about its role. But it's just another tool apart from uterine artery Doppler to predict preeclampsia. I don't think there's any extra advantage of doing an ophthalmic artery Doppler in the present scenario.
Purvi, would you like to say something? Dr. Purvi?
Yes, ma'am. Good evening, ma'am. So, ophthalmic artery Doppler, I would say the same thing as sir said. It is a screening tool. It is one of the screening tool. Not so widely used, but definitely people are putting light into it. The more evidence we get, maybe it will come into the practice near future. So that is it. We see two peaks in peak systolic value, and we take a ratio of that. So yet to be used in our practice, but definitely in future we see a little optimism in ophthalmic artery Doppler.
The upcoming one, the promising one about the study is in the late trimester after about 32-35 weeks, where it has been predicted that if you could do the ophthalmic artery, it could be predictive of very severe preeclampsia. So at points like that, where if you have an ultrasound machine with the correct Doppler, like sir said, the probe is very important. It may be of value like a PLGF SFLT ratio, which would predict when to deliver the baby.
Okay. So it is something that we need to read about and keep our options open and actually start learning to do it. Now, this is my question to the gynecologist present over here. If a raised PI is seen directly in the mid-trimester scan, is there any way to treat that? Purvi?
So, ma'am, we need to understand that even if we have a race PI in first trimester, we are not treating it. We are just screening for preeclampsia a little more aggressively. So, in case we have because many patients miss first trimester scans still, especially in our area, people don't come, people don't show up, or they directly come for the fifth month or the mid trimester anomaly scan. So in these patients, a race PI, I believe benefit of doubt, we should give aspirin. We have to closely monitor this patient, especially for their blood pressure, and a growth assessment maybe 28 weeks, and then every month, if at all things are going fine or any indication, we should do an early growth scan with all the Dopplers as indicated.
So here we have one controversial point where I want my experts to say that the woman has been diagnosed with a raised PI at 20 weeks. So do you want to give aspirin?
giving aspirin again, like ma'am said, is a controversy because the studies shows that above 16 weeks, if you go ahead and give aspirin, it really doesn't help. But doing something is better than nothing is what people practice, and they still give. How much of it is of use is something that we'll have to study about and present papers on. But as of now, the recommendation is to start it only till 16 weeks of gestation.
Ma'am,
So
one point I want to. Yes,
Yes,
the
Dr. Dhawan.
old Lancet journal says that there is a chances for the late bookers that who come are for mid-trimester anomaly scan after 20 weeks or 8-20 weeks. In a 20 to 24 weeks window and maximal 20 to 22 weeks, the use of aspirin prevent the stillbirth, preterm birth, and the PIH is 10%. In between 20 to 24 weeks, it prevent these three things at 5 to 3%.
So that's the problem. The
Yeah.
detection rates of these are extremely low. So when we say about preeclampsia, the chance that with a uterine artery Doppler at 20 weeks that they will develop preeclampsia is something that we can debate. That's why I said very specifically that we'll need more data on it. Might be it is promising, but without data, it's still not at a recommendation level, not accepted.
And sorry to
Yes,
interrupt.
Chintan sir.
Sometimes giving the aspirin is a practical thing also, because when you detect raised PI and you counsel
You
the
have to do
patient that you have a higher chances of developing PIH and growth restriction, but still we cannot do anything. That seems bad, as a
Yes,
doctor. So
yes.
if we start, it would be a good psychological boost for the patient.
That's exactly. Doing something is better than doing nothing.
True.
Yes.
Chilappan sir, your final word. Aspirin at 20 weeks, yes
practically
or no?
Practically speaking, research apart, practically speaking, you have come across the patient for the first time and you're seeing this, better start. What is the problem? It is cheap. It has been found to be effective, like Dr. Dawal has mentioned in other situations also. And anyway, we are going to stop at 36 weeks. So what is the harm in giving it? There's no harm in giving, even without sufficient research, as Dr. Anu and others have said. I think certain things we are doing it practically also. Practically also we are doing.
So thank you. So the consensus is that we don't have enough proof, but we have enough proof that we can use it. It's not a recommendation, but you can't just detect something and not do something.
Yes.
And it's harmless also. It's harmless.
But madam, that's one point I want to add is, do not start that heparin after 20 weeks. Aspirin we can start, but the heparin is a no role, is a empirical.
Okay.
Because most of IVF clinic, I seen the report that the patient came at mid-trimester scan and there is changes of high uterine artery PI and early FGR. Even in twins pregnancy also some SFGR is there, and then start at 20-23 weeks heparin. Already tropoplastic remodeling already occurred. Then there is no any role of heparin except anticoagulation. That's it.
Okay, thank you. So now this patient is on aspirin 150 milligram HS. Uterine artery PI is still above 95th centile or 1.5 moms. How are you going to monitor this case? When will you call her or send her for the next scan? And what do you actually want to know from that scan? When you write your indications, scan for this. So what do you actually want to scan her for? And when do you want to scan her next?
We would like to call her at a more frequent interval. Be it a normal case with a normal uterine artery Doppler, we would have called it for, for the scan at around 28 weeks for the growth scan. But, since she is having obvious risk factor, I would like to call her at 4 weeks interval. And at that time, anyway, if I would like to check the biometry and the growth of the fetus, with her expected fetal weight, and we'll check whether she is not falling below less than 10%. And along with that, I would probably see the umbilical and MCA Doppler also. And
Devi, sir.
probably, we do have one more chance to look at the fetal heart, because she was being scanned at 20 weeks. So again, we can better evaluate the heart at 24 weeks. Apart from that FGR issue.
Dr. Dhaval?
Yes, ma'am. See, this is the mid-trimester anomaly scan was done, and still the uterine artery PI is high. So I want to figure out that what is the culprit. Does the placenta is abnormal? That means there is short, thick placenta, or any heterogeneous mixed sense of placenta. Any past history of PIH, maternal obesity, diabetes, and any autoimmune disorder. So keep this patient in close surveillance. After 20 weeks, suppose I did my anomaly scan, I recall this patient at 24 weeks. Again, monitoring the uterine artery, DV, and umbilical artery. There is no role of MCA Doppler before 30 weeks. So it's in this picture, MCA is no role. And after at 24 weeks, suppose the growth is low centile, or it's the normal growth, or it's the early changes of IUGR, or it may be the evolving changes of IUGR is seen. So according to this finding, I put this baby on close surveillance either 2 weeks or 4 weeks. And suppose this patient is meets pre-eclampsia screening, and patient came to do from well-to-do family. So apart from the uterine artery PI, I can suggest after it from the 24 weeks is SFLT PLG ratio.
Okay. So today
Ma'am,
our
just to add on.
topic is basically Dopplers. So Dr.
Yes.
Anu, what do you actually want to see in the Dopplers?
Ma'am, in the we will definitely reassess the uterine artery Dopplers, because now it is recommended to continue till term to measure uterine artery Dopplers. In addition, the umbilical artery Dopplers would be done and seen that it is normal for the period of gestation. I would just like to add, since we are working on Dopplers, we should never forget the mother. And if you're a gynec, you should always start screening them for increasing BP values. Probably even ask her to do weekly monitoring at home, at least if you're going to call her only after 4 weeks.
Okay, so that
So
is
you
a very
mean to say,
important point.
just a minute, madam. So you mean to say just because uterine artery Doppler is raised, we have to, start doing Doppler every 4 weeks? From
No, sir.
20
No,
weeks
sir.
we
If
have
there is an
seen her.
FGR.
So again at 24, 28, like that we have to go so frequently just because the
Growth,
uterine artery Doppler is high?
no, sir. Growth scan. If the growth scan shows FGR.
What is the traditional teaching? Like, suppose the uterine artery Doppler was normal at 20 weeks. When is the growth scan expected to be done? It's as late as 30 to 32 weeks, right? Am I right, or madam?
Yes, sir.
Dr. Asha, madam, am I right? If it is 30
Earliest
to
at
28 weeks, if
28
uterine
weeks.
artery Doppler is
Earliest at
normal.
28 weeks.
No, 28 is not mentioned in any guideline. Any fetal medicine specialist here, if they can clarify. See, if the mid-trimester anomaly scan, uterine artery Doppler is normal, we expect the growth scan only around 30 to 32 weeks. See, leave apart what we are doing practical. It's practically everybody is keeping the probe every month, right? That is a different story. But if it is at 30 to 32 weeks, the growth scan, so when a mid-trimester uterine artery is high, are we expecting that from 24 weeks we start doing just on the basis of uterine artery Doppler, or 24 and 28 weeks it's just a clinical evaluation, and instead of doing at 30 to 32 weeks we do it at 28 to 30 weeks?
If the mid-trimester uterine artery is high, then the earliest we keep the monitor these fetus at 24 weeks and 28 weeks, but the closely monitoring that uterine artery.
Is it by ultrasound and Doppler, or is it by clinical? That is my
clinical, sir. Because
exactly,
actually
right now we're not
India,
supposed to be doing the ultrasound at 24 and 28 only because the mid-trimester uterine artery Doppler was high. We are preponing the 30 to 32 week growth scan by to 28 to 30 weeks. But
28 weeks, as early as 28 weeks.
28 weeks. But before 28 weeks, growth scan will not have a role. Like, see,
Yeah,
at 20 weeks we have done uterine artery Doppler. It is high. So the 20, she will anyway be called for a clinical visit after a month, that is 24 weeks, and again after a month at 28 weeks. So at this time, we are supposed to be monitoring her blood pressure, her weight gain, her symphysis pubic height, and this oral glucose tolerance. These are the things to be done in this way. So growth scan, if you want to do, then it will be 28 to 30, as that is the earliest. Just because we are having the
I think we
ultrasound.
proceed now to the next case, and we'll have a reason to get an answer to what we are talking about. So this is a 28-year-old, gravida 2 para 1. She has one vaginal delivery of 4 years. Her BMI is 32. She has presented directly for the growth scan at 28 weeks. Wants to know if the baby is okay, as people are saying we can't see your tummy. So, she has an MTAS report where only uterine artery was done with a normal PI. No anomaly was detected and growth was at 30th percentile. Now her growth scan is done. The weight is at the 5th centile. Umbilical artery PI is more than the 95th percentile. DVPI is also above 95th centile. MCI PI is below 5th centile and uterine artery PI is normal. So, is this SGA or IUGR? That is my first question. Is this SGA small for gestational age or IUGR?
It's a madam early FGR because the umbilical artery is more than 95th centile. So see the Delphi consensus criteria. According to the Delphi consensus criteria, the according contributory part, it's not a solid part. Solid part says that less than 3 centile is a pakka early FGR. But in contributory part, in your USG report says that expected fetal weight is less than 10 centile, plus umbilical artery more than 95th centile, plus uterine artery is more than 95th centile. Means among these three things, the two thing is positive. That means it's considered at early FGR.
Okay. So now we are sure that this is FGR and not small for gestational age.
Yes.
Because in SGA, your Dopplers would be normal.
Normal, yeah.
Yes. So now how are you going to monitor this case? How often are scans indicated?
So monitor scan is every 2 weeks, two weekly, but the scan is 4 weekly.
I didn't get it.
How would you monitor this case, right?
Yes.
So monitor this case, madam, every 2 weekly, because there is changes of early FGR.
What is the method of monitoring? What would you do in that monitoring?
It early FGR at this fetus at 28 weeks, right? So
Yes.
I monitor this fetus. It's doing a first of all, it's a maternal side because it's BMI 32. So I rule out that diabetes status, doing a GTT test, BP monitoring, right? Two things. Okay, regarding this fetus point of view, I monitor this Doppler, that is umbilical artery, and this yes, DV. And the fourth thing is growth pattern, the trajectory of growth. Because for the minimum time is needed for trajectory and trend, the growth float is minimum 2 weeks.
Okay. So how often, Dr. Anu, how often would you do the Dopplers? And growth is to be assessed at 3 weeks. It cannot be properly assessed in less than 3 weeks.
Before less than 3
Yeah,
weeks,
but
yes.
minimum 3 weeks is for the growth. But how often do you want to repeat the Dopplers here? Because out of 4, you have 3 abnormals.
Yes, ma'am. So waiting for 2 weeks to do even a Doppler might be catastrophic at this point of time. Ideally, it has to be done every 3 to 5 days because it's already in the abnormal planes at 95th centile. In addition to that, I would also ask the mother, I would teach the mother probably to keep the kick counts also. If the kick counts are coming less, if the patient feels that the movements are less, she would be called in earlier than that to either do a CTG or a Doppler at that point of time, depending on the availability.
Okay, so that was my next question, that is there any role of fetal movement count? So you've already said that. So when do you want to do a CTG? This is a severe FGR, early FGR. So is a CTG indicated?
As long as we know how to interpret, early preterm CTGs are very difficult to interpret because the B2B variability is going to be highly inefficient. But if you are good at interpreting it with the decelerations and finding out early decelerations, if early signs of decelerations, it would be a good indicator. But B2B variability might not be a great indicator.
Okay. So now, Purvi, is there any role of measuring the deepest venous pocket? Deepest vertical pocket.
Vertical pocket.
Yes, ma'am. So yes, it becomes a part of our biophysical profile, as one of the indicators is a DVP. So keeping that also in mind, but definitely as a whole scan, DVP should be there. We have to monitor BPP, the growth, and the Doppler, all three in this pregnancy.
So now, how long do you think we can carry this pregnancy? With these changes, with a 5% growth at 28 weeks, how long can we carry this pregnancy?
Ma'am, this early FGR trigger for delivery from my side is a DV changes.
Yes.
If the absent DV, then I would like to deliver this
So
fetus.
that is what. So your trigger for delivery is going to be DV, right?
Madam,
Yes.
I would like to add something.
Yes, sir.
Madam, trigger is always, okay, that whenever there is a, ductus venosus flow is abnormal, you have to deliver because acidosis has already taken place. But actually, practically speaking, the trigger for delivery should be as per the weeks of gestation and as per the capacity of your neonatal unit. So say if it is the fetus is playing around 28, 29 weeks, definitely you can wait till your DV flow is abnormal. Or then, if the baby is around 30, 32 weeks, then you can move slightly an upward position where you can take the reversal of this umbilical artery as a trigger. If the baby is around
Thank you
34
for
weeks
that
plus.
point, because what you have said is very important, that we have to take decisions based on the capacity of our neonatal unit.
Yes, ma'am.
So that is a very, very important point that you brought out. What about steroids, magnesium sulfate?
Yes, in FGR,
not?
yes, required before delivery.
Ma'am, also I'm going to wait till the DV is reversed. She has completed 28 weeks, right? Now her DV is reversed. Till then you wait, then you won't have time for steroids, right?
Yes, madam.
Yes. So then when do you plan to give your steroids?
Suppose the DV is in this case, suppose the DV is changes in view of absent DV flow, then I give the steroids and give the magnesium sulfate along with the steroids and wait for these magnesium sulfate dose and then to deliver.
Okay. Now,
because I'm not, because there is a two school of thoughts here, madam. In early FGR specifically.
Yes, sir.
First thing is, can I say something?
Yes, sir.
Here is a two school of thoughts. In absent DV flow, this is a stage 3. I saw so many patients that necrotizing enterocolitis, that means is echogenic bowel. It's very progressively it's seen in some fetuses. Suppose we are waiting for the stage 4, means there is a reverse DV, right? So when the plan for this reverse DV and plan to deliver this baby up to reverse DV and then deliver when the reverse DV is happen, then what happened that already is a echogenic bowel. That means there is a ischemic changes in bowel is there in sonography in view of echogenic bowel. and suppose this baby is carrying get out of the uterus and everything is fine. But these echogenic bowel in view of ischemic changes in of these bowel in clinical necrotizing enterocolitis, it's postnatally is very trouble.
Okay. Okay. So you've given your steroids. So what steroids, do they change the Doppler findings?
Yes, change because
Yes,
it's inflammatory process. So it's a false interpretation of report of this Doppler change. Up to 36 hours, madam. Maximum 48.
Okay. So having Doppler changes coming back to normal does not mean that the baby is getting better. Is that right?
Yes.
Yes. Yes. So these are the basic things. These are the
Also in the
recommendations. Yes, Dr. Purvi?
Ma'am, we need to rule out aneuploidies also, as it is an early FGR and the patient did not have her first trimester screening or any markers done. So we need to keep an eye on the aneuploidies also, ma'am.
Exactly, madam. See, basically at 28 weeks, if there's already an FGR, we will have to also rule out fetal infections by the toxoplasmosis and other, this rubella, cytomegalovirus, all those things. And the second is we have to offer a karyotyping or a chromosomal microarray to this patient. Because early FGR, these two things have to be ruled out. Then only the subsequent monitoring that, okay, our fetus is safe from aneuploid chromosomal abnormalities, it is safe from infections. So now put in all the energy towards the monitoring so that at the end of 30, 32, whenever we get the baby, that doesn't have other comorbidities in the NICU. And regarding Dr. Dhaval's point, he said very nicely that waiting for the reversal leads to NEC and all that. But that is why nowadays they have introduced the aortic isthmus concept. That once the this ductus venosus is going down, so they also add in aortic isthmus. And if the aortic isthmus reversal is there, at that time you give the steroid, because steroid once we give, then we expect that the delivery is done between 72 hours
Yes.
to 1 week.
Practically, sir, practically in our setup, stage 3 is trigger for delivery for early FGR.
Yeah, that's it. So when it almost reaches the base, A wave reaches the baseline in the ductus, we should give the steroid and then also the magnesium sulfate and go. Magnesium sulfate again only between 26 to 32 weeks. After 32 weeks, magnesium sulfate may not be useful. But one interesting thing is if these are the patients who are also simultaneously getting into preeclampsia and severe PET and other things, these hypertensive disorders. So invariably, even after 32 weeks, if you give Maxel, the postpartum rise in or the intrapartum rise in the blood pressure can also be averted. There are, I mean, certain authors who are saying that even up to 34 or 36 weeks, use magnesium sulfate freely. At least the loading dose give it if the mother is showing these tendencies.
Thank you, sir. Thank you. So now we proceed to case 4. This is a case of fetal anemia. 27-year-old, gravida 3, para 0, 2 medical abortions with amenorrhea, 20 weeks has presented for the first time. Her antenatal tests were done because she's come for the first time in the OPD. She is O negative. Husband's blood group is done. He's B positive. Advised MTAS, which was done, and it was found normal. Now, what will you advise? A Coombs test? Direct or indirect? Which test are you going to advise?
Indirect Coombs
Always
test.
indirect. Indirect. How often is the test repeated?
Once
the
only.
indirect home test is on booking from second is a 16 weeks and third one is a 28 weeks. And after 28 weeks, if the ICT is negative, then antenatal first dose of NTD.
And if it is positive?
If the positive, then there is a two things. ICT positive, that means we have to rule out antibody identification test. Which type of antibody is positive? D plus M, Levy, KL, small E, small C. And according to these things, we have to monitor MC Doppler and patient this fetus also to rule out the fetal anemia and hydropic changes and polyamorous.
Titers also has to be
Titer is very
understood.
important.
Yeah, yes. Then
Actually,
the
madam,
point is
actually,
titer
in that
is
one, at the admit that when she has registered, that time itself ICT will be indicated because she has
yes.
had 2 previous medical abortions.
Sir, she
Yes,
has
So,
come directly at 20 weeks.
as at that time, immediately
At
we should do
booking.
the
At
titer and
booking.
the
The first should
ICT
be
and
always
its
at booking.
titer. And when it is positive, we have to see at what level it is positive. 90% of the patients will be positive up to 1:8 or 1:16. Then you have to talk to your laboratory. What is the critical value? Like in our Baruch laboratory, it is in certain kits they are using it is 1:16. In certain kits, it is 1:32. So these
Yes, sir.
patients
Sir,
have to be monitored. And
there is
third
a
point, like Dr. Dhaval said, that to see for the other antibodies, that facility is not available in most of the cities in our state, except
sir,
Ahmedabad maybe.
sir,
So
these antibody identification tests doing generally blood there's a Red Cross blood settings they are doing in our request. And the second thing is that even NIPT also we can suggest.
yeah, NIPT, but
For the blood
that is to know the baby's
yes, baby's blood
is negative. No, but now I would like to know from you, Dr. Dhaval, which
yeah.
test exactly you are asking the Red Cross to do? Because this is
Antibody
important.
antibody identification test.
So which all antibodies are they identifying?
There is a so many antibodies, capital C, small c,
MMS,
E,
and all
capital
those
E, KL for killer antigen,
KL.
Levy antibody. There is a list of antigen
I
antibody
agree to
identification.
that. But how much are they charging? And is it easily available? Because as far as I know, only Prathama lab in Ahmedabad is doing it.
Yeah, Supratech Ahmedabad also doing. And suppose you are request specifically, especially in Red Cross blood bank, that pathology is also doing. In Anand, in my setup, Anand they are doing.
Achha, okay. And how much are they charging for that? How much are
around 2,000, sir.
2,000. And how many days are they giving the report?
Within 40, maximum 48 hours.
Okay, thank you so much.
And the second thing is 99% ICT titer test done is a gel method. Very few lab is methoding by the tube method. Ideally is a tube method. Suppose the gel method.
Bharuch, our Gunjan lab, they are doing tube method. We have specifically requested them.
Yes, because suppose gel titer is high. Yeah, gel method titer is higher.
Yeah, that's more accurate. Tube method is more accurate.
More accurate.
Yeah.
So now, sir, this patient went home. Her MTAS was normal. Now she presents at 32 weeks. Again, disappear in between. She's directly come at 32 weeks. The MCA PSV is more than 1.5 moms. There is subcutaneous edema seen all around the fetus. What does this mean? And what is the diagnosis now?
It is most likely RH isoimmunization. It is most likely RH isoimmunization. And because of the RH isoimmunization, there is fetal anemia at this point of time, most likely.
So how will this case be managed now? She's 32 weeks.
IUT. Require this urgent IUT, madam.
Intrauterine transfusion. So you need to refer to a fetal medicine person to transfuse.
Yes.
But if she's my patient and I ask her that you go to a fetal medicine person for transfusion, she's going to ask me 10,000 questions. So how am I going to counsel this patient? What do I say to her? How do I explain the details of transfusion and the risk? And will the baby need it again? You know, there are so many things that the mothers are going to ask. So how are we going to counsel this case?
And the most important thing that we would counsel her and we will reassure her is that though there is the affection of the baby in utero, the baby is having anemia. This condition is treatable as well as preventable. So by doing some intrauterine treatment, this is one of the only few conditions of the fetus that is treatable in utero. So by doing the treatment and early treatment, we can probably prevent many of the complications. And that's how the fetal medicine consultation as well as the treatment is very much necessary. For how long and for how frequently, the baby is to be given this transfusions, probably the fetal medicine person who is treating that would be in a best position to do that. But we can counsel her that frequently your baby would be monitored by Doppler and all that values. And as per the values, the baby may need some a few transfusions in utero.
That's right. For my own sake, I would like Purvi to explain exactly how is a fetal transfusion done.
We use O negative blood, ma'am. What do we do is we have calculators in the Barcelona website. We go there and before starting the transfusion, it has to be done in a operation theater, preferably in all the sanitary conditions, all the hygienic conditions. Pre-transfusion, we need to arrange O negative blood. It has to be irradiated blood and leukodepleted blood. We see the position of the placenta. We can either give it in the cord or we need to give it in the hepatic vein, depending on the position.
Baby moves, then what will you do?
So you can give some sort of a paralytic agent to the baby. Usually these babies are sick and they are heavy because they have eye drops all around. So usually they are not so frequently mobile. But even if you feel, you can give some sort of a paralytic to the baby. Intramuscular paralytics can be given, vancomycin can be given. After that, we have the blood. We need to see how much blood we have to give. So usually we calculate it from the calculators in the Barcelona website. There's a tag called fetal anemia. In that, we need to see how much is the hemoglobin pre-transfusion and how much want it to be, and it gives the exact amount of milliliters to be transfused to the fetus. Accordingly, we transfuse, and then post transfusion also we take the sample again and then see how much is the hematocrit value. So pre-transfusion hematocrit and post-transfusion hematocrit has to be seen. In this, if at all the NIPT is not done as Sir said, we can use the same blood to check the fetal blood group as well. But that is not absolutely needed, but we can use the same blood to check pre-transfusion.
Dr. Anu, you want to add something to that?
Ma'am, just like Dr. Purvi said, it is not very required to give any neuromuscular relaxant to the baby. But in case you're planning to give, it has to be when the baby is lying with the face up and the spine down. Otherwise, it becomes very difficult for the transfusion to happen. And the other thing being, like Dr. Purvi was saying, the hemoglobin and the required amount should be calculated. So always there's a doubt how. So the first prick that you take, you do take out the baby's blood, and there is a hematocrit calculator that is usually kept beside us, with which we do calculate on table, or if you have a lab which can quickly give you, you send to the lab immediately, get back the hematocrit, calculate the delta, and that delta is then started off as mLs. So we note down every 100 ml that we give, we have to note down, okay, this many are done, and then at the end of the push, we take out and see, okay, now how much of hematocrit we have corrected. And once the delta is over, we say, okay, today's procedure is done. And usually there is a revisit after 10 days to check that everything is fine. Usually everything is fine. Baby would not be hydropic at that point of time. The general callback to check for MCA and usual the changes that we see is in 3 weeks time. So she's 32 now. Most likely by around 35, she's going to require another transfusion. And at that time, we transfuse again. And since the next visit is going to be at around 38, we generally don't leave her till 38. At 37, we do call her back and see the MCAs again. Baby is term, adequate weight. If there is no signs of anemia, then a delivery can be thought of as per the obstetric management. If there is already an anemia, then it is better even at term not to deliver her, but to actually transfuse her once again and then deliver the baby, preferably not to deliver an anemic baby even at term.
But why? See, I'm a simple gynecologist. I'm asking you, means she's already
anemic
2 weeks. My nursery takes care of babies which are even 28 weeks. Why can't I just deliver her at 32 weeks? Do a cesarean, take it out, even if it's anemic. They can give a transfusion later.
Ma'am, the amount of transfusions required and the kind of heart failure that the baby is going to have at that point of time, if you deliver an edema, a baby with edema, is going to be a huge, negative at monitoring and managing in an NICU. So even if your NICU is able to manage a 400 grammer, a baby with severe hydrops is going to be much more difficult to handle than that. So it's always preferable and non-anemic.
Thank
babies.
you. Because that was.
I think here a joint consultation with the fetal medicine specialist, the neonatologist, and us gynecologist. The three people have to simultaneously, discuss and answer that question of yours, madam. Why not at 32 weeks? Because I have seen situation where our fetal medicine specialist ordered us to do it at 34 weeks. I think it all depends on the total condition or the status of the baby. All the entire parameter, it all depends on that. And the neonatal setup.
Ma'am, at the hospital where I work, it's a multi-speciality unit with a very active perinatology unit. We have all the three specialties with our smallest babies being delivered at 400, 450 grammars who go home without much of neurological deficit. So even in a center like ours, the perinatology unit, which consists of all the specialists that doctor said, the gynecologist, the fetal medicine specialist, the people who do interventions, and the neonatologist sitting together, we still aim at term deliveries of a non-anemic, non-hydropic baby, rather than a baby who would go into NICU even for a day.
So thank you. So now
Madam,
she has delivered.
One point, madam. One point.
Yes, sir.
Now, Dr. Anu, you are in a very privileged situation where the whole team is under the same roof. If you take care of places like Raipur or like Bharuch, our patient has to commute maybe hundreds of kilometers before they can reach a proper center. Then, so a lot of this is also required, backup services for the family and all that. So I think in that scenario, want a delivery after a single I don't say that deliver at 32 weeks. By giving a transfusion at 32 weeks, we are getting 3 weeks time. So we might reach 35 weeks.
No, sir. That is where the idea is different. So in 3 weeks, the baby is going to be again anemic. So delivering after the transfusion.
At 32 weeks, we have given a transfusion, just hypothetical. And at 34 weeks, we steroid her and deliver it out by 34 weeks and 4 days before the 35th week sets in.
So even better than that, theoretically, if we are going to do that, even better than that would be steroid her at 32 weeks itself, wait for 48 to 72 hours and deliver her at that time where there is no anemia seen, rather than waiting for 34 weeks where again she'll be partially anemic and then you're going to deliver. The outcomes are way better when the baby is absolutely not anemic. So if you just wait for another 3 days, the edema is going to subside, the heart functions are going to be better. Whereas at 34 weeks, it's going to start worsening again. So once you see that the hydrops has settled, that would be the better time to deliver than 34 or 35 weeks later.
So now what is the perspective for her future pregnancy? Dr. Chintan, sir.
Yes, ma'am.
What is the perspective for future pregnancy?
Regarding the isoimmunization,
yes.
If she is getting we are giving the NTD injections antenatally as well as postnatally.
The baby has received transfusions and everything, and she has delivered at 38 weeks. We've given her NTD. Now, what about her next pregnancy?
First of all, there are all chances that the baby may be Rh negative in next pregnancy. So then the prognosis would be excellent. If the baby happens to be unfortunately Rh positive again, then probably we need to monitor her because there are chances of repeat these things and the cascade may be beginning at an earlier stage than.
So would you be giving anti-D to the mother in pregnancy, and then at what time? Dr. Dhawal, even your inputs I would like on this.
NTD, madam, 0, 16, and 28. So ICT negative on booking 16 weeks and 28 weeks.
No,
ICT
she will be positive next
No, no.
time. She's going
She
to be
will be
positive.
definitely positive. She is going to be positive.
She is ICT positive, and then
once the
once
patient
ICT
is
positive, there is no
NTD
role
has
of
no
NTD.
role to play. There's no role of NTD
No
once
role of.
the patient is positive for ICT.
There is a no role of madam NTD.
Correct.
So even in this particular patient, since she is positive at so early, subsequent NTDs are not required. Subsequent ICTs are also not required. Only monitoring by middle
MCA Doppler,
circulatory,
polyamnios, and hydrops. 3 things.
middle circulatory PSV is required because once she has received the transfusion also, subsequently you have to monitor by MCA PSV only.
Okay. So in the future pregnancy, she may end up all good or all bad, depending on the blood group of the baby.
Yes.
If she is affording and wants the husband's heterogeneity tested, whether husband is homozygous positive or heterozygous positive, that might be of some use, but it's an expensive test.
Thank you, sir. So now that we are at our last
And one more recent advance is since 8 years in Europe. There is an option from NTD from 14 weeks to 36 weeks. That tablet which is used in anti-cancer drugs. It's called the nipocalimab. First trial is happened in Europe and almost successful. Within 5 years, it will come in market. It's nipocalimab.
Okay. Okay. So now we have a 38-year-old, Gravida 1, known case of chronic hypertension, and she has presented at 34 weeks for her growth scan. Her previous first trimester, mid-trimester, and 28-week scans were within normal levels. The fetal weight is at 15%, which was 50% at 28 weeks. The Doppler uterine artery 70%, umbilical at 95th, more than 95th, MCA less than 5th, and the CPR is 1.23, which is less than the 5th percentile. Is this late FGR?
It's a madam, very late. Okay, so Chintan sir, continue. I will add some points.
No, that's fine. Ma'am, if we go strictly according to the definition, if the baby is having, expected fetal weight less than 10 centile, then only you can label it as an FGR. But still, if there is another criteria that the baby is not growing, if you have a previous scan report, if the baby is not growing at the same pace as it was growing at 28 weeks, according to that terms, the baby is considered FGR. And again, looking towards the Doppler findings, the baby is definitely considered to be a late FGR. Okay, Dhaval bhai, you can carry on.
Yeah,
this 34 weeks. One question which I have for myself, that all these CPR and all are only calculated when the fetus is less than 10th centile. Am I right?
Madam, yes. According to the extended definition, okay.
Or like sir said, there is a shift between 2 standard deviations. So if that is also there, it can be considered as late growth restriction.
It is 35%. It's 35%. It's not 2 centiles. It was 50%. Now it's down to 15%.
According to this 34 weeks and according to the these Doppler changes, it's set in late FGR stage 1.
Yes.
But one more point I want to add. This umbilical artery is high resistance flow. It's not happened suddenly within 15 days. It started from around 28, 30 weeks and it's happened high resistance flow at 38 weeks. Because
but she came at 28 and now she has directly come at 34.
Okay, that means that 28 is umbilical artery is normal, I assume.
Yes.
So now how are we going to monitor this case? Will you do an immediate cesarean? If yes, why? If no, why? She's already 34 weeks, na? Daily monitoring. What Dr. Harshad was saying, बाद में IUD हो गया. So why not give just steroids and take it out?
No, there is no point of view immediate C-section at 34 weeks. Why go for C-section at 34 weeks? Keep this is the stage 1 in Barcelona. Keep this baby close surveillance, 1 weekly follow-up, and suppose this biophysical profile you can do in this patient is a twice a week. That's it.
Okay, so this point I actually wanted to bring out, that it should come from the mouth of fetal medicine people. Chintan sir, your take on this?
Yes, ma'am. I fully agree. Just by these findings of the Doppler, we cannot go for an immediate CS. Ideal, our aim should be to deliver the baby at 37 weeks, unless there are changes in the biophysical profile or CCTG.
And maternal side.
Yeah, correct.
And maternal side. So, do you think there's any role of fetal movement count?
Yes, this is a
Yes,
biophysical
definitely.
profile. That is definitely.
Okay. And what is the thing in the biophysical profile which is a trigger to deliver?
Trigger for deliver here in late FGR, there are the four players. The first is fetal breathing movement, which I shown in Doppler by put the Doppler at fetal nasal side, and even diaphragma we can move the in the scan. Second is a fetal movement. According to the rule of thumb, 10 to 12 movement per day. The third thing is here is this CPR ratio, right?
Yes, sir.
Yes.
And
These
the
three.
CTG after
Yeah, and
34
fourth CTG. Yes, there are the 4 players are running in late FGR.
Okay. So thank you very much. Now I request everyone to give one take-home message, which gynecologists like me will remember and apply. So Chintan sir, we start with you because you are the first one I see on my screen.
Okay. The most important thing while monitoring the baby, whether the baby is normal or there is an FGR, the Doppler is an integral part of every antenatal surveillance, and I think every gynecologist or obstetrician must be well versed with the basic Doppler studies.
Purvi, Dr. Purvi.
Yes, ma'am. Ma'am, I would like to put emphasis on the first trimester scanning with the uterine artery screening. So, a lot of patients in our practice still are coming directly for anomaly scan. They don't know the importance of the first trimester screening. Maybe because we are, I don't know, they're late in booking, or the gynecologists are not aware of the importance. The inverted pyramid of antenatal care is what I would like to put emphasis on.
Thank you. Dr. Dhaval?
2 points I want to give a take-home message. The first thing is dating scan, means anti-scan. 11 to 14 week scan is very, very important, because there is sometimes is misguided is a early FGR, late FGR, and we seen that it is first trimester scan is there in patient, then put the reassign the date, and that baby is absolutely normal. So this early scan is very important. And the second thing is late FGR, because 70% in cases is a late FGR, and it's almost 2 to 3 cases per week we are encounter this late FGR. So these are the 4 players we have to play with the late FGR. And the CP rate, cerebroplacental ratio is not a trigger for delivery.
Okay.
Only cerebroplacental ratio, madam.
Okay, it's just a trigger to monitor closely.
Yes.
Yes. Dr. Anu?
Hi, ma'am. So there are 2 things that I wanted to put across. Just like everybody is talking about the first trimester screening, it would be worthwhile to call up your lab, whoever is doing it for you, when you're doing the biochemistry along with it, to also give you the preeclampsia risk calculated in your in your report, and not just your trisomy risk reports. So if you are including PLGF, yes, they would add that too, but without that also they can give you an assessed risk, or else at least put it on your computer. You can calculate it yourself and assess, rather than just going by the numbers of it. Sometimes we do err on it. We just saw uterine artery, which is 2.8, but everything else seems to be fine. And Dopplers are one thing which we cannot always be so relying upon. So there needs to be checks and balances in place. And the second part of it is that in the late trimester, don't jump into delivering babies preterm just because there has been one report which is saying that there is something abnormal about it. Always recheck. Always ask your radiologist or your fetal medicine person or yourself to have a recheck of your Dopplers if it is not a very emergent situation and it is not in your stage 3+ category. Ma'am, you're muted. You're muted.
Chilappan, sir?
I think I just want to say that treat the patient as a whole. I mean, maternal parameters, lab parameters, and ultrasound. Lab parameters and ultrasound are just tools for the obstetricians. Most important is the maternal characteristics and her clinical condition. That's the most. All the three should be having equal weightage. Because what I see in my practice, this is my simple statement. What I see is I come across patients who have just gone to for a checkup. They have an ultrasound report, but they don't have a hemoglobin or a blood group. It has no meaning. Doesn't have a weight. Doesn't have a blood pressure recorded. So it has to be maternal parameters, lab parameters, then ultrasound. This all the three should be give the comprehensive care, or your should form the base of that pyramid. What Doctor, I mean, is mentioning. Was it Kypros is mentioning? So all the parameters have to be. That's my state.
Thank you so much.
Ma'am, I have one or two questions.
Yes, sir.
If anybody has a knowledge, is there CCTG machine available? And if it is available, when? Because in all the talks, regarding the FGR,
No,
they
sir,
say that,
it's not available.
Not
Not
available.
available.
Okay. So it's just
CCTG is manufactured by only one company in the whole world. Just like, see, all these are all pharma and this instrument, supported. CCTG is only in America, it's there, and that also in certain places. No, there's not a single unit in the whole country in India. Even in Europe, only at certain places. We can use our regular CTG machine judiciously. We have to have an eye for a preterm CTG and a term, near-term CTG. There are two different things. Those parameters are there by various authors that we should have. Number one. Number two, like Madam was mentioning PLGF, then somebody was mentioning SFLT. All these are all research situations. Even if I have seen so many cases where PLGF is showing very high risk, but the patient is absolutely normal throughout the whole thing. You're anxious, something is going to go wrong. Finally, it comes to the clinical evaluation only. Her height, her weight gain pattern, her blood pressure, her sugar levels, her symphysis, pubis fundal height. These are the most things. Other things, I feel it is all pharma driven. If we do PLGF from, suppose I get it done from a lab X in Bharuch, then the fellow from Chennai or from Bangalore will come, oh, sir, that is not FDA approved. That is not European Commission approved. So, I mean, they all try to
manipulate
this business.
So ultimately,
we have to evolve our own plan with patient in the center and how we can use these tools, what are available to us to give a best care to that patient. That is my.
The second question was, as we are having good criteria for the trigger for delivery in case of early FGR, all the Doppler criteria and all, Barcelona all. Regarding late FGR, we say that we rely more on biophysical profile and CTG, but do we have some strict criteria as to guide the when to deliver? And I mean to say, what criteria would prompt us for an immediate delivery in a baby who is less than 36 weeks old? I'm talking of late FGR. So
Sir,
do we have
actually,
criteria like biophysical profile less than this, or
if
So
there
the
are,
only
That is
criteria
where,
are all
see, late FGR again, for example, in your particular example, already her CPR ratio was below the 5th centile. Now, if you take CPR ratio only, there are 20 different authors who have given 20 different graphs, and every graph has its own 5th percentile. In some graphs, it is at 1. Some graphs, the 5th percentile even is at 0.8. CPR 0.8, and some it is at 1.2. So your patient had CPR at 1.23, which was less than 5th percentile. So if we go, only thing it tells us is be careful with monitoring. Finally, it comes to CTG only.
sir, the
Overall picture.
percentile,
Overall picture.
Chilappan sir, the percentile is the less than 5th centile is different at every week. At every week, that value is different.
So see, that is what I'm saying. See,
Yeah.
once you percentile is different at every, but once you say it is below 5th percentile, means it is a warning that something is going wrong with that.
Agreed.
So finally, it has to be the clinical scenario only. The mother's parameters are fine or not.
Chintan sir, for your question, usually, like sir was saying, it is about how bad the mother situation is and how the CTGs are. If the CTGs are reactive, we generally continue the pregnancy, or else the umbilical artery Doppler should go for reversal or something like that to consider delivery.
Even
Or
if
they reach
late-
37 weeks and then we deliver her.
Even
Sir,
if
I
late
think-
FGR, even in late FGR, if we have to time it in such a way that suppose midweek around Wednesday you are doing the CTG, by Saturday do the Doppler. So because CTG you have to do it when the baby is active, and Doppler you have to do when the baby is resting. So you have to give it on 2 different days. So you are covering the whole week, and right like that you have to go ahead. And if any parameter comes down, then we have to be alert.
So why I brought this point, because they say that in late FGR, the baby is very vulnerable to even subtle hypoxia, because the baby is not used to the hypoxia in the early life. So sometimes, before the umbilical Doppler gets reversed, the baby may succumb inside. So I mean, the criteria
That
for
is because
trigger.
the brainstem chemoreceptors get activated. So that is why what we were taught in our fetal medicine class was that you need to see the breathing movements, which are the first to disappear, and the variability, which becomes less. So if you see decreased variability or you see less of breathing movements, terminate that pregnancy. Don't wait anymore.
Got it.
So these were the triggers that we were taught in our class. So I think it's been a really great discussion.
Hello, madam. Termination is by LSAS or we can give an induction?
Ma'am, if your baby is in trouble, you're going to deliver by cesarean section. You don't want to lose the baby in delivery.
Again, here it will be a controversy.
Ma'am, how to deliver is your
terminate.
choice.
It is not that only by cesarean. You're supposed to be giving, if the CTG is fine, you're supposed to be inducing the
Positive induce, yes.
And if the baby is performing well with the contractions, continue. But if the baby is not performing well, then go for cesarean.
Again, the answer, just like how we say,
as you said, madam, because that fear complex, the litigation, and the fear of getting bitten by the mob, it invariably makes us.
But that is what actually happens.
Yeah, I agree.
Because you do a PV, you see it's a good Bishop score, you start induction, again you cannot give oxytocin when your baby is already in trouble. Then what, you're waiting, and that it's not progressing. And if you say now we have to do it and you get meconium, they will be at your throat. So practically what happens is when you have a baby which is in trouble, it usually ends in cesarean section. Means that is what is actually happening. I think it's been a really great discussion, and we've been sitting for 2.5 hours. I hope the audience has enjoyed it as much as we have. I'm really grateful. Chilappan sir, Chintan sir, Dhaval, Dr. Anu, Purvi, Sujya, Chandra Swami ma'am has joined in. Uma ma'am is still there. Sameer is still there. You can all put on your videos. We'll take a photo and then we would actually end the session. Thanks a lot for being here with us. Thanks a
Thank
lot.
you, ma'am. It was
Actually,
really
Dr. Ashok
informative
sir
and
is
enjoyable
also
to see.
there, ma'am.
Namaskar.
Asha ma'am, I
Yes,
think Dr. Ashok sir is also there.
Ashok sir would not be there. His computer would be there. So anyway, if he is listening in any way, thank you so much, sir. Uma ma'am, would you like to say a word?
Hello.
Yes, ma'am.
Very nice discussion, madam. And we came to know many things in this session. Thank you very much.
Thank you. Samir, you want to say a word? Chandra ma'am, you want to say something? Dhaval?
Thank you,
Otherwise,
madam.
Namaskar, Shubhratri. Please remember me when you're nominating for Food Drug Committee. Namaskar. I seek everyone's
Thank you and
support
best
and
wishes, ma'am.
blessings.
All the best, ma'am.
Thank you and best wishes,
Thank
ma'am.
you. Thank you. Thank you. Thanks a lot, Mehul. Thanks a lot, Corona Remedies. Thanks all viewers for being with us. Thanks a lot.